Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observation and commentary on the JCO article, Does Aggressive Surgery Improve Outcomes? The interaction between preoperative disease burden and complex surgery in patients with advanced stage ovarian cancer. An analysis of GOG 182 by Neil S. Horowitz et al. My name is Robert L. Coleman, and I am Professor and Deputy Chair in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. My oncologic specialty is gynecologic oncology. Primary epithelial ovarian cancer remains one of the few solid tumors in which patient survivorship is closely linked to the amount of initial post-surgical residual disease volume. Initially quantified by a seminal report in 1975, Griffiths and colleagues noted that, quote, survival was uniformly poor if the diameter of the largest residual tumor mass exceeded 1.5 centimeters, irrespective of the total tumor volume, unquote. In addition, they noted that extensive surgical procedures, in other words, high surgical complexity procedures, without removal of disease to this benchmark, did not influence survival. From this point on, various definitions of what was considered, quote, an optimal resection, unquote, have been championed and even required as eligibility in prospective clinical trials, such as phase 3 studies of intraperitoneal chemotherapy. The persistent message is that there is a disease residuum threshold below which patients undergoing optimal surgery appear to have a better progression-free and overall survival. More recent reviews and analyses of large primary ovarian cancer treatment data sets have suggested that the benchmark, which is more clearly and consistently definable, as well as having the greatest impact on survival endpoints, is the attainment of no visible residual disease, a so-called R0 resection. Since most newly diagnosed ovarian cancer patients present with diffuse intraperitoneal disease, the surgical procedures necessary to achieve an R0 state may be quite complex and include one or more bowel resections, peritoneectomy, and employment of extirpative procedures of the upper abdomen such as diaphragm stripping and/or resection, splenectomy, and partial liver resection. What has been unclear and confusing in the literature is whether these procedures can overcome some innate destiny being leveraged by the cancer's intrinsic biology. In other words, are tumors that present with organ-invasive disease characterized by biology that not only defines this growth pattern, but also informs the vulnerability or sensitivity to chemotherapy? And can surgical resection alter these characteristics? Recent work in genomics have noted differential characteristics in expression profiles that define cohorts likely to be left with large volume residual disease and those in whom post-surgical therapy may not work as well, even when controlling for histology and stage. However, it is also known that large ovarian tumor masses have geographical differences of perfusion, hypoxia, and cellular proliferation, which might be altered by their removal. Further confounding the issue are survival analyses from retrospective studies of advanced stage ovarian cancer patients who present with limited volume disease and are compared to those who are debulked to this same benchmark, say less than 1 centimeter. Some studies show that these survival curves to be overlapping, supporting the surgical effort. Others show worse survival for those achieving the same surgical result, suggesting an intrinsic biological effect. The current article by Neil Horowitz and colleagues attempts to shed light on the controversy by examining a subgroup of patients from GOG 182, a large randomized controlled trial of chemotherapy in women presenting with stage 3 and 4 ovarian cancer. The trial accrued over 4,300 patients and failed to demonstrate that any of the alternatives to paclitaxel carboplatin were superior in terms of progression-free or overall survival. The lack of treatment effect, as well as the large sample size and excellent availability of case report forms documenting pre-surgical disease distribution and surgical procedures, made it a good trial to interrogate this question. The authors used a metric to describe disease distribution and surgical complexity to evaluate surgical outcome on survival endpoints. The subgroup they evaluated were those in whom post-operative tumor residuum was less than or equal to 1 centimeter. This represented about 62% of the enrolled population. Not surprisingly, they demonstrated that disease volume was inversely prognostic, namely, more disease was associated with worse outcome, and associated with other known adverse prognostic factors such as age, stage, and performance status. They also reaffirmed that women undergoing R0 resections had substantially better survival compared to other, quote, optimal patients with macroscopic residual disease. In addition, they highlighted, as expected, that patients with more extensive disease at presentation were more likely to undergo complex surgical procedures, and within this high disease category, more complex surgery led to higher rates of R0 tumor residual. And so, with the multiple interacting variables, they sought to address which of these variables, disease score, surgical complexity score, or residual disease, was most important to survival. In the end, disease score and residual disease status were more influential than surgical complexity. In fact, among all of the patients who received an R0 resection, which was about 32% of the study subgroup, outcomes were worse if they presented with high volume disease. And among those with the worst disease status, achieving R0 status was only marginally better in terms of progression-free survival as compared to those achieving small volume macroscopic residual disease. However, R0 was attained in only 12% of patients. There are a couple of take-home messages from this study. First, disease volume at presentation has both known and unknown effects on survival, and diffuse large volume disease likely reflects innate biology. Number two, some of the innate effect may be modulated by aggressive surgery, but is infrequently obtained. Third, R0 resection should be the goal of a surgical attempt, since overall it has the greatest modifiable impact on outcome. The weakness of this kind of analysis is that it's difficult to prospectively implement. Since we have difficulty assessing the primary variables, namely disease volume, surgical complexity, and the likelihood for R0 outcome before operating, these data only primarily inform what we do after committing to surgery. It's a bit of tail wagging, subjecting a large proportion of patients to potentially unnecessary intervention. This is amplified by the fact that those patients not achieving at least a residual of less than or equal to 1 centimeter were excluded from the report, yet would have been equally assessed for surgical resection at study entry. Further, higher surgical complexity is also associated with higher morbidity and mortality, which incidentally were not assessed in this report. Fortunately, better tools are emerging to potentially identify those in whom an alternative approach, such as neoadjuvant chemotherapy, might be more prudent. One is the use of a validated nomogram, which assigns probability to R0 resection based on imaging and clinical parameters. Another is laparoscopy, which assigns a score based on disease location and volume. This latter approach is interesting as it serves not only to identify a cohort of patients in whom R0 resection is extremely unlikely, but also provides additional information to the patient regarding the anticipated surgical procedures that may be necessary to achieve R0 resection, allowing the patients to participate in the approach decision. Since neoadjuvant chemotherapy compared to primary surgery among high-risk patients has not been demonstrated to be inferior, the additional information gained from this approach can better inform the patient and her providers to options of intervention. This concludes this JCO podcast. Thanks for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.